the Radiation Safety Officer for Mount Sinai. I'm also Professor of Radiology. I will try to summarize the stuff that you need. They might ask you some questions. So what I did, I have some pamphlet that they're gonna distribute among you. It's about 100 multiple choice questions. So you try to test yourself to see the knowledge of radiation. What we're going to discuss, what's the definition of RAM, REM, gray, sievert. Now it's better. Radiation protection principle, Allaro, monitoring, how do you monitor your radiation, pregnancy, if you get pregnant and you have to work with radiation, what's the law? Shielding in Cath lab, verification of lead eyeglass. You have to be careful because some of the eyeglasses they sell in the market is not real, and you have to test it to make sure it's really lead in it. Mention a little bit about NCRP 160, NCRP 102 about recommendation for Cath lab, and patient dose reduction. That's a very, very important topic because lately regulations are changing, especially about patient skin dose. The Joint Commission requirement is a new requirement that I will try to cover. So radiation absorbed dose is energy deposit per unit of mass. That's very simple. Used to be, we used to call it RAD, abbreviation for radiation absorbed dose, but now is the universal gray, which is a mostly European use it, and it's 100 times more than RAD. Effective dose, it uses the quality factor. Quality factor means how much damage that type of radiation is going to influence on the skin. So gamma ray and X-ray for you is 1, quality factor is 1. But if it's an alpha ray, then quality factor is 20. So effective dose is simply absorbed dose multiplied by quality factor. So when you get your exposure report from the badges, radiation badges, the unit is in effective dose, not RAD. So the quality factor I mentioned to you is just simply, then the unit of effective dose is sievert. And again, 100 rem is 1 sievert, is the new unit they use. Typical exposure value, you've seen them, a long radiography used to be 20 millirem, now is about 20 millirem, about 10 millirem with the new machine. Dental X-ray is about 300 millirem. A CT used to be 3,000, but now is about 2,000 millirem. Average annual reading for a nurse in a hospital, right? It's about 70 millirem. A pilot from New York to Philippines gets 13 millirem. So can anybody tell me why a pilot gets this much of radiation? What's about it that he gets? If you calculate from 13 millirem annually, will be about 700 millirem. So a pilot gets 10 times more than a nurse who works with radioactive material. Why is that? Anyone? A nurse use radioactive material on a daily basis. The pilot is 30,000 feet in air, so the background radiation is higher and higher. That's why a pilot gets 10 times more than a nurse in a hospital. You follow me? Now, average annual occupational, people that they work in radiation, but they get different type of amount of radiation. So if you work in a nuclear waste disposal, you get 1.24 rem, which is 1,200 millirem. In a reactor, they get 0.33 rem. But again, in a broad medical institution like Mount Sinai, you get 70 millirem. A pilot gets 700 millirem. So these are typical exposure that you and we get on a daily basis. In 1987, they did a study of they call it NCRP, National Commission on Radiation Protection. And they said the average American gets 3.6 millisievert, 360 millirem, and the average each American gets, right? And you see, they break it out. 0.14 was from nuclear medicine. Then they said it's changing because now you have interventional radiology, interventional fluoroscopy. So the numbers are changed. In 2009, they did another study, and it came to 6.2, 620 millirem, average American gets. Is that clear? Now, if you go to Denver, because of the high altitude, you get 1200 millirem, and that's part of life. You can't change it. Now, in a cath lab, in a typical cath lab, you have a beam here, right? So this is the tube, this is the eye. When you have a beam like this, the scatter is 90 degrees. Am I right or wrong? So remember, scatter is a very, very important topic for you. The more radiation you give to the patient, the more scatter to you. The less radiation you give to the patient, the less exposure to you. So you have to learn, I'm going to explain to you how to reduce radiation to the patient. And this is not something, it's optional. You have to learn once in your lifetime. It's like parking a car. If you learn how to park a car nicely, gently, you will be okay forever. So I suggest you, I recommend you that you learn how to use the fluoroscopy machine effectively. Not just put your foot on the pedal and then, talking to the nurse. No, you're giving a lot of radiation to the patient. You don't want lawsuit. Now, for measuring your radiation, we have these badges. You've seen them. In a badge, you have a lot of information. This is a typical whole body badge. Institution, department, location, name, what period to use. And then we have a ring badges. For your purpose, you don't put your hand in the beam that much, so you don't give, we don't recommend ring badges, but you have these badges. Now, how to use the badge is very simple. Exchange the dosimeter at the end of every month. Don't use it for 2 months or 3 months. Must be returned. Do not share with someone else. You use it Monday, I use it Tuesday. No, absolutely not. Do not take it to different hospital, because if you have a high reading, there is no way they could investigate what happened. So make sure if you work in 3 hospitals, you have 3 different badges, 3 different hospitals. Do not use it in another institution. Store the badge. When you go home, make sure the badge is outside, free of radiation, and then when you come back, you use it again. How much radiation we are allowed by law to get? This slide is very important because they ask you in the exam. So, whole body you are allowed to get 5,000 millirem per year. Organ 50,000, lens of eye 15,000, skin 50,000, and your lifetime, you just take your age and multiply by 1,000 millirem. So if you are 33, let's say 30 years old, your cumulative exposure should not be more than 30,000 millirem or 30 rem. Is that understood? Now, I ask a question here. Among all of these, which one is critical to you? Which one of these you have to watch it very, very carefully? If you have a lead apron, this is not the issue, right? Because you are protect the whole body. So you, as the cath lab doctor, you need to be worried about your eye. So you have to have lead glasses, right? And you have to make sure you don't get more than 15 rem per year to your eye. What happens if you work, you love your job, but you get pregnant? It's no problem. Declaration of pregnancy by radiation safety is not mandatory, it's voluntary. But once she declare means she write a piece of paper, I'm pregnant. That's all it means. Then the institution obligate to measure the exposure radiation to the fetus. And the fetus cannot get 500, more than 500 in 9 months. which is roughly 50 millirem in any month. And it's very simple. The doctor is going to have a lead apron. There is a badge under the apron. You monitor the badge, and the badge has to be on the belly, and it's on and on, right? It's very simple, but I strongly recommend you that if you get pregnant, do it. At the end of each year, you should get 4 or 5. 4 or 5 is simply how much radiation you got during last year. So any institution you work with, they have to give you one of these at the end of the year. The basic fundamental of radiation safety program is Allaro. It stands for as low as reasonably achievable. If you look at it, different regulations, they say differently how to implement it. In New York City, they say level 1 and level 2. Level 1, if you get 10% of your animal exposure in 3 months, which is about 125 millirem, then you get notification. Level 2 is 30%, then you get investigated. Now, 90% of the people, they work in Cath lab, they get investigated for what exposure? Anyone? To their whole body or lens of eye? Lens of eye. You follow me? So you have to watch how to work with the fluoro on the table. Now, if you look at this slide, it's very important. I summarized it many millions of information about exposure during the fluoroscopy to the operator. Operator means you. Now, if you look at all these procedure, neck, lens of eyes, hand, this is per procedure, this is annually, and this is, when they say annually, they assume 1,000 procedure per year. So this is a very good slide if you want to have some idea how much radiation you get annually per year. And these are the author and these are the references. In order for us to calculate how much radiation you receive, institutions, they have different way of doing it. One institution, they put one badge. So they put on the collar around your neck. Then they know how much your eye exposed to, right? Then based on Webster formula, they calculate how much you receive under the apron. It's very easy. That's one method. The other method is some institution, they give 2 badges, one outside, one inside. The problem with 2 methods is that the doctors switch them around and the calculation becomes totally wrong, and you get such a high radiation and you will be investigated for the rest of your life. So my suggestion is go with the easy life. Take one badge, make sure it's always outside around your neck, and then you know how much your eye gets, and then from that one they could calculate how much under the apron get, right? So there is benefit and disadvantages of having one badge compared to 2 badges. I'm not going to go over that because we have a lot to cover. Lead eyeglasses is very important. It's less than 1 centimeter of less than 1 millimeter of lead in it, but it reduces by 98%. So lead eyeglasses is crucial for you. Now, sometimes in the market, they sell you something that is fake. So all you have to do, take the lead glass, put it under the fluoro, and you will see if it's whitened, that means it's lead. If it's no reaction, that means there is no lead in it. It takes pretty much 1 minute, less than a minute. In a cath lab, usually you have image intensifier here. These are the ceiling shielding available for you, patient positioning, and then you have table on the side for shielding. So you have a lot of shielding available for you to use it. These are different type. We used to have this in Mount Sinai. It's like $80,000 and it's hanging on to ceiling, so it doesn't give you back pain, the whole lead. Lead is about 20 pounds of lead every day, 8 hours a day. So eventually you get back problem. So this was an idea, but the problem is it gets on your way all the time. So it depends if you need it or you don't need it. But this is another one on the market. There are plenty of them in the market, but it depends which one you like. In 2000, 2011, Joint Commission started saying, hey, you're giving too much dose to the patient. You have to record it. So that was the first time Joint Commission started to investigate the patient dose. So at that time, they came up with dose aware, and some of the machine, they wouldn't record the exposure to the patient, so they had to buy this software, or some people, they were writing it with the hand. Some people, they try to do all kinds of logbook to keep the record. These are also available if you want to buy this one time, but it's reduced the exposure by a factor of a lot. It's really a piece of lead in a sterilized gel. Then ICRP came out in 2011, and they said that they used to think that 2 gray used to give you a cataract, but now they found out that 50 rads, it gives you cataract to your eye. Now, how much radiation you are allowed to get in your eye per year? Anyone remembers? I just told you 3 minutes ago. 15, right? So if you go to 50, then you start worry about your eye. Do you follow me? But by law, you're allowed to get 15 per year. ICRP started to say that you are getting right now 15 rem per year, or 15,000 millirem per year. But they came in England and Europe, they came up with another idea. They said, oh, you are not allowed to get more than 2 rem per year, average over 5 years, and each year you cannot get more than 5 rem. So they are making it more stringent in Europe than United States. In United States, they could not pull that out, and still your exposure, your eye could get 15 rem per year. Are you with me? Is that clear? 15 rem per year to your eye, you're allowed. Joint Commission again, it came back and it says, if someone gets to the skin of the patient 15 gray, sentinel event. Sentinel event, that means is a investigated incidence, right? That means you have to investigate what happened. How did you give this much dose to the skin of the patient? Then they came up with the idea recently, 2-3 years ago, that you have to have the patient dose in a retrievable format. That means I could come to the hospital and I could ask you, this patient from 6 months ago, I need all the information. How much radiation you give to that patient? So you have to have it. 99% of the machine right now, they do that automatically for you. We had 2-3 machines in pain management that we had to do it by hand. So that's also solved. NCRP 102 recommends that only people that they are necessary in a Cath lab should be in a Cath lab. If they are not, they are not. They have to have lead apron. They have to stand behind the lead sheet. And the lead should be 0.25 millimeter equivalent. You cannot use less. You could use more. If you use more thick, then you have back problem, all kinds of other problems. Lead apron. The new regulation, they changed the name to protective garment. Can anybody tell me why? They hated the word lead? No, because the new lead apron is not made of lead. It's made of composite material, which is about 20% less weight on you, and it gives you the same protection. But when you bend it, it breaks. Do you follow me? Lead is nicely bent, but the composite material is bismuth. It breaks when you bend it. And when you want to get rid of a lead apron, don't throw it in the garbage because it's a hazardous material, lead. So you will get citation. Make sure that you return it to the company and you take a piece of paper that you disposed it properly. Basic fundamental for radiation protection is time, distance, shielding. Time, you reduce the time of exposure. Distance, you take away from the source, right? And shielding, you put lead apron and other things. Now, in 2007, there was a 53 years old and he had a stent replacement. Then again, in 2008, he returned to East Asia and had 5 hours of fluoroscopy. That's a long, long time fluoroscopy. And you could see exactly what happened to his skin. And these white stuff that you see is because of a cream, because of the pain that he was going through. There was another case in 2000 that the patient came back after 4 to 6 weeks and they saw in the back of the patient reddening. After 16 weeks disappeared. They thought everything is okay. He's fine, right? With antibiotic and other things. But then again, 18 weeks, 18 months, it appeared again. This is the picture of the same here, but with the closed caption. So eventually they had to do the skin graft and solve the problem. You do not, I give you advice as a friend, you do not want to have case like that, because lawyers, they would love to follow you. And it's very simple. You watch how much fluoro you use. You watch your foot, how much you push the pedal. That's all. If you look at the dermatologists, they have this very nice, and you see these are after how long, and these are skin, and you see majority of them is 5 to 15 gray. That's where you have to worry about. So 5 translate to about 30 minutes of fluoro. If you are giving more than 30 minutes of fluoro, you have all kinds of problem. This is the general advice for doctor treating, and you see these are the things. 0 to 2, no visible effect. 2 to 5, sometimes maybe reddening of the skin. 5 to 10, definitely the patient has to test himself to make sure there is no reddening. 10 to 15, you have to ask the patient to come back to make sure what happened. And above 15, definitely something wrong. Is Sentinel 11A. Oops, I'm sorry. I went too fast. Okay. Now here, NCRP 168 is a guideline. I think you should get a copy of it because this is your lifetime job. So get a copy of it and look at what it says. NCRP says if you go fluoroscopy time, you could take any of these, let's say skin dose, air kerma, all of these. But fluoroscopy time is the easiest one to follow. If you have more than 30 minutes, is the first notification. A nurse or a technician should say, hey doc, 30 minutes. That means watch it. Every 15 minutes, he should tell you, hey doc, be careful. You follow me? So it's first notification, second notification. This is recommended by NCRP 168. Now at Mount Sinai, we have 2 levels. Up to 5 gray, up to 5 gray, we inform the patient when you go home, watch the skin to make sure there is none. If it's more than 7.5, we ask the patient to come back. This is Mount Sinai policy at the bottom. Radiation biology. There are 2 types of biology. One is deterministic, one is stochastic. Stochastic comes from statistic. It might happen, it might not happen, like cancer. But deterministic, we know what's going to happen. These are radiation biology. If someone asks you, this is single exposure to skin. These are the effect. These are the threshold. These are the onset, how long it takes. You could also have whole body, the damage, the dose, and the effect. So it would be nice for you, if you are interested, to look at the radiation biology. Fundamentally, how do you protect yourself by not injuring the patient's skin? First, you ask the patient, have you had a stent? Have you had fluoroscopy, right? This is pre. Then you ask during the procedure, and watch it, not to give too much. And then after, so before, during, and after. This is the fundamental. How do you reduce the dose? Scatter is the most important subject for you. Dose reduction, patient ultimately reduce the patient's reduce the patient dose, reduce the dose to you. 2 easy rule. When possible, stay as far as you can from the fluoro, but Sometimes it's not possible. For lateral objection, stand on the II side. Make sense to you? If you don't, I'll show it to you. So which one do you have, which one you choose to be? Look at this picture. And these are, when it's red, that means too much radiation. So you don't want your eye to get too much radiation. You want to be on this side, right? How do you reduce the patient dose? You minimize the fluoroscopy time, right? Keep the patient as far from the tube, modify the tube angle if possible. Grids should be removed if possible. Refrain from boost. Do not use boost. Use last image hold if possible. Collimator, electronic modification, pulse fluoroscopy. Communicate with the staff. If you want to know more about this, go to this website, imagegently.org. And this is a revolution that has started for the last 10, 15 years, and it will not stop. And these are everything I said. I summarized it for you in one slide. What do you have to do to reduce the patient dose? There are many ways to get cataract. One of them is ionizing radiation. But if you get cataract as a doctor, doesn't mean that it was from radiation. It could be diabetes. It could be all kinds of tobacco. What we know about radiation is a weak carcinogenic. Its probability is function of dose. And there is no evidence below 10 rem that you get anything. This is a good slide because it gives you risk in life. You could work as a smoking one pack of cigarette, you lose 2,400 days of your life. If you smoke female, 1,400 days of your life. These are all risk in life. But if you get radiation 1 rem from 18 years old to 65, you lose only 51 days of your life. So risk is compare what's benefit versus risk. And these are references. So I have 1 minute left. If you have any question, I'll be happy to answer any question you have. Please speak louder because it's so long, too far.
What are your thoughts about the lead caps? Do you recommend we wear them?
Which one?
Lead caps or hats that they sell?
I mean, you have to practice. In my opinion, there is nothing to lose by using the lead. But if it's practical, for example, this gravity, Dr. Sharma was kind. At one point, we purchased along 10 years ago. It was $80,000, right? In design is a good idea, very good idea. But when you want in practice, you see it's difficulty. So you have to try it and see if it's useful, do it. Otherwise, I wouldn't. Time, distance, and shielding. Don't forget, reduce the time. Do not, one of the physicists put the nail at the bottom of this pedal, so when the doctor would press, the nail would hit him. So do not press the button unless you want to see something. That's the key. Any other question? There are handouts with multiple choice question for you to practice yourself for the exam. If you have any suggestions, please let us know. We'll make it better and better. I've been coming here for almost from the beginning with Dr. Sharma. It has been such a pleasure. I love to work with him. And this pamphlet is nice for you. You know, the answer is in the back. So you could try and test yourself. Do you really know it and you don't know it? And all the stuff that you see in the pamphlet, I just reviewed them all with you. So it's good for you to know. If you have to choose one item is regulation about the patient skin dose is getting harder and harder and harder. So please watch it. I know you're trying to save life. I do know that. But be a little bit cautious how much you put your foot on the pedal. Thank you so much. I appreciate that. Thank you.